Hello, I'm Michael DiPietro. I'm a pediatric radiologist at the University of Michigan, and I'll be speaking about sonography of the pediatric hip, specifically about developmental dysplasia of the hip, and then about the painful hip and hip effusion. I'm Michael DiPietro. We're going to talk about sonography of the pediatric hip. Two aspects of the pediatric hip that we'll discuss are first regarding developmental dysplasia of the hip, or also noted as DDH, and also about the child with the painful hip, in which we're usually looking for a joint effusion. Regarding DDH, this talk will concentrate on providing an orientation to the anatomy, what it is that we're seeing, and describing static and dynamic aspects of sonography of the hip when looking for DDH. In regard to the painful hip and joint effusion, we'll be discussing how to identify an effusion, and then, if requested by the clinician, a technique of aspirating the fluid for analysis. So to begin with DDH, the reasons for DDH are varied, the indications and associations. Very often on a physical examination you'll hear that the child has a click or more noticeably a clunk at the time of the physical examination. The clinician might note that the hips are lax or loose. There's an increased association with breech presentation. And sometimes the children have other deformities such as torticollis or a wry neck, usually related to fibromatosis coli. The child could have a club foot or less severe foot anomaly, metatarsus adductus. And both of these entities are often associated with a child who might have oligohydramnios and tight fetal packing. And then there is a family predominance, a family history sometimes of DDH. The term DDH is a broad spectrum, which can include anything from a dislocated, non-reducible hip, all the way to perhaps some mild immaturity of the acetabulum itself, and varying categories in between, as you can see. And there are static and dynamic aspects to this entity, which is what we observe. Regarding the static study, we're looking at the morphology, the position of the femoral head, and the maturity of the acetabulum. And regarding dynamic, we're looking for the stability or laxity of the hip, dislocatability, subluxability, or if they're already dislocated or subluxed, reducibility. As with most musculoskeletal sonography and sonography in general, orientation is essential, and that is really an aspect that will be stressed in this portion of the talk. Sonographic technique is also very important. In coronal screening, and scanning with the coronal plane, most of the sonography is performed from the lateral aspect. You can here see that the child is on his side. The position of the child isn't as crucial, just as long as you really do maintain the coronal projection. Now, for demonstration purposes, the hand is high up on the transducer, but if we were actually scanning, the hand would be down at the bottom of the transducer, actually in contact with the child. But the hand was removed just so you can see the orientation. And this is the type of view that you might be seeing. Basically, the hip joint is a ball in a socket. And the coronal view that is obtained, is really very similar to a frontal radiograph. The advantage of sonography is that you can see the portions which are not yet ossified that are cartilaginous. And being a ball in a socket, there's really three essential questions that we address. This is what we address when we're doing our study. This is what I describe when I'm explaining the findings to the parents when we do the study. So first of all, is the ball, i.e. the femoral head, in the socket? Does the ball stay in the socket, which is an aspect of the dynamic study, looking for laxity? And is the socket well formed, meaning that is the acetabulum mature? And all three aspects are quite important. Now, although the coronal view on sonography obtained from the lateral aspect of the hip, as you saw earlier, is very similar to a frontal radiograph. Because we're coming in from a lateral approach, the way it appears on the screen is as though you rotated the radiograph 90 degrees, as you can see in this drawing. And keeping this in mind will help you considerably to understand what it is that we're seeing. So in these pictures, that little diagram is in the corner for your orientation, and you can see what we see on the sonography is the femoral head. This is the ossified metaphysis. This is the cartilaginous acetabular roof. This is the osseous acetabular roof. This would be seen on an x-ray as well. This is the lateral aspect of the ilium. These are gluteal muscles coming around, and you can see indeed the ball is within the socket, as you see in this picture. Now here's one where it looks a little different, and you can see that the head isn't as far into the acetabulum. This is the medial aspect of the acetabulum here. Instead of being down in here as the other one was, this one is now drifting laterally. And this is some subluxation. And in addition, the acetabular roof is a little more sloped, is not quite as straight and horizontal as it was in the other one. So this is a child who's showing some aspects of developmental dysplasia. Here's one that's even further subluxed. You can see the femoral head out here and the greater trochanter here, and this is the ossified portion of the proximal femur. This is all cartilaginous acetabular roof, which is actually echogenic and pushed up somewhat. And here's the acetabular roof here, which looks steeper. So you can see in these three examples, we're going from normal to a more severe subluxation or displacement of the hip. This one, it's actually outside the acetabulum. And here's the femoral head. Acetabulum is here. And actually, this is very, very far posterior within the acetabulum, which we'll illustrate shortly. This is a completely dislocated right hip. So what would be important here is to see whether we're able to reduce it or not. So another dislocated head, you can see the femoral head, you can see the greater trochanter. This is the ossified proximal femur. And this femoral head, if it were normal, would be way, way down here, which is much more medial. And again, using this picture as your orientation, and you can see its similarity to a rotated frontal radiograph. This is towards the patient's head. This is towards the patient's feet. This is lateral. Now here is one where the head is actually pretty well positioned. This is the medial aspect of the acetabulum. This is the greater trochanter. These are the gluteal muscles coming around laterally. And this acetabular roof is steeper than it should be. Now, I want to show some anatomy that we alluded to a little bit. If you go very, very posterior in this coronal view, you see this large bulk of cartilage. This is the very posterior cartilaginous portion of the acetabulum. In this portion of the acetabulum, you should not see the femoral head at all. And if you do see it in that plane, it means that the head is displaced far posteriorly. Now here's a newborn with actually, if you look at this carefully, you can see the ilium and the acetabulum here, and the acetabulum here. And both femurs, even though you cannot see the femoral head because it's cartilaginous, if you drew them in, you could just see that there's no way that these heads are here where they should be. So these are bilateral dislocated hips. This child also has spinal dysraphism, and this dislocated hips at birth are referred to as teratological hips. But I'm showing you this picture to show you how sometimes on radiographs even it's very, very obvious that the hips are dislocated. Now in this child's sonogram, this is the femoral head here, which now you can see, and this is the ilium, but you're nowhere near any of the normal anatomy of the acetabulum. This is very, very posterior, just as it was on the radiographs. So you can see here, rotate that 90 degrees counterclockwise, and you get this picture. Now, in the same child, you can see the femoral head here. This is the very, very posterior aspect of the acetabulum. This is all that cartilage that we showed, and here it is, the femoral head is right over it. So this is a very, very posterior dislocated head. This is the transverse view, which we are going to discuss shortly, but this is anterior, this is posterior, and this is also very much laterally and posterior dislocated. This head should be down here. And in a moment, you'll see your orientation for those views. Now, the transverse view, this child happens to be in a Pavlik harness that you can see here, but is also done from the side, done from lateral, but the transducers turn 90 degrees, so it's transverse to the baby's body. And the key to understanding that view is very much like an axial CT scan. So you can see what it would look like on a CT. This is the ultrasound. This is a CT scan of a child. He's in a cast. His hip had to be reduced in the operating room. You can see both hips are in. But I'm showing you the analogy of this to the transverse ultrasound view. So if you took that axial CT, rotated it 90 degrees, it would look like the transverse view on sonography. There's posterior, there's anterior, there's lateral. The transverse view when you're first starting out is a little harder to understand, but once you understand the concept and relate it to a CT scan, it makes it a lot easier. So turn the CT scan sideways. This is the pubis, the ischium. Here's the femoral head, anterior, posterior. And on a sonogram, this is anterior, this is posterior. This is the part of the ischium here. Here's this posterior cartilaginous portion of the ilium, and this is the femoral head. You do not see acetabular morphology very well in the transverse view. That's not why you do it. You really do it for position. But this view equates to this view. And that's right where it should be. This is a hip that's subluxing a little bit, and this head should be down here more, but it's drifting laterally and posteriorly. And this is an older scan. This is the femoral metaphysis. There's the epiphysis. The ischium is here. This head should be way down here, and this is drifting quite a bit laterally and posteriorly. So again, we saw this on the coronal view, the very posterior cartilage of the acetabulum. This is what that cartilage looks like in the transverse view. Here's the femoral head. This is a normally positioned one. And you can see again the femoral head within the acetabulum here is right where it should be. Another picture. Now in this cine study, this is normal. I'm showing you a transverse view. This is posterior, this is anterior. This is the femoral metaphysis, and here's the head. And this is right where it should be. And as I'm scanning a little bit superior and inferiorly, we're seeing more and less of the cartilage from this very posterior aspect of the acetabulum. But this is right where the femoral head should be. Now, this is a maneuver where we're abducting and adducting the leg. So when you can tell by the position of the metaphysis here. So here we will be abducting in a moment when this looks more there we go, abduction with the knees coming out, and then adduction when this is a little bit more horizontal on the screen. And hips that are very, very loose, when you adduct, when you bring the knee towards the midline, the hip tends to slip out a little bit. This hip is normal. This isn't doing anything here. And then what we'll also do is then we'll keep the child adducted, and then we'll push like a piston. This is the Barlow maneuver. And we'll see if the hip goes out or not. So we have a couple of dynamic case studies to show. This is a coronal view, and this is normal. This is really, here's the ball, here's the socket. You see the greater trochanter coming into the picture. Here's the medial aspect of the ischium. You can see the acetabular roof here, and this all looks normal. Now in this one, there's a little bit of laxity. We're still coronal. And you can see how this distance here is increasing, and as I'm pushing on the hip, it's slipping a little bit laterally. It's not excessive, but there is a little bit of laxity here. Sometimes if the child is really just a few weeks of age, this could fall into the realm of physiological laxity, but you have to follow it. It could be still under the influence of the maternal hormones, and which makes the hips a bit loose. Now this is another coronal view, so still in the same orientation, superior, inferior. The distance with the medial aspect of the acetabulum is much greater. Here's the acetabular roof, and this is kind of riding on the edge. And I was trying to, when I'm trying to abduct and push the hip back in, but I was unable to reduce it fully. And this is all useful information for the clinician. Now we're switching to the transverse view, kind of like the CT scan, and now I'm just doing some abduction and adduction. And you can see that the ball is in the socket. There's no widening of this medial space. There's no slipping laterally or posteriorly. And this is all normal. In this view, the gluteal muscles are coming around from behind and then coming to or over the greater trochanter, which is just out of the picture. Now this one, you can see the difference, also in the transverse view, but there's a lot of slipping going on here. This space is widening, and this is a loose hip. This is what you want to avoid. You don't want the child to go on and then have a hip that looks like this. The acetabulum is dysplastic. Instead of a nice cup, this is a very steep roof, and then this head is completely out. And that's what you want to avoid. And Dr. Harkey is one of the leaders and pioneers in this field, and he warns us about performing this study. It really takes a while to get some expertise and experience, but I'm hoping that this presentation will give you an overview and a chance to get started in this area. Now, a couple of problems common problems. One is regarding the transducer if it's not aligned properly, so that you really are seeing the true coronal standard plane. What I'm showing you here, this was done intentionally, is that at the beginning of the loop, this is normal right there. Nice acetabular roof, lateral aspect of the ilium, the ball's in the socket. But if you have the transducer tilted or turned or transposed a little bit incorrectly, it's almost like flying a plane, which you have pitch, yaw, and roll. All these things can happen to the transducer with respect to the lateral aspect of the body. You can make it look very abnormal. And you can see if you just froze on that picture right there, you would think that's a very dysplastic, shallow acetabulum with a steep roof, but it really is just an artifact of projection. So this comes with experience, and then hopefully having the proper orientation of mind will help, which will help a lot. The older patient can be a challenge, and generally if the child is older than 6 months, I'll really question why are we doing a sonogram instead of just doing a radiograph. But this is a case that came through, and it was a little different. It was an outside pediatrician. It was very hard to track the person down to change the study, so I said, well, I'll just try it. And I think we were successful, but it shows you it can be a real challenge. This child's 14 months old. There was the toes were going out a bit, and you want to know if it could be due to DDH. And this is the kind of view you get. And you can see the real challenge because a lot of ossification is already present. You don't see the acetabulum that well. Here's the femoral head. Here's the acetabular roof. When I did this study, I felt that the head the ball is in the socket. The head isn't within the acetabulum. The acetabulum looks fairly normal, but you could have told all this much more easily and quickly on a radiograph. This is a coronal and just showing how we're trying to find the right planes. But you get the sense that it is in the proper position, but it can really be a challenge in the older child. And this was the impression from the report that I explained all this to the clinician. He later called me later on and kind of apologized for ordering this study. But I think we did answer his question, but it was a lot more work than a radiograph would have been. And I told him what my feeling was about this. And I also usually put in the reports if the parents were present or not and how much they know, which can be helpful to referring clinicians and knowing what the parents were already told and what their understanding is. Another area of pitfall that's quite widespread among everyone that does DDH is really regarding if you have a hip contracture or bowing deformity. And these cases are not that common, but it is common for them to be misinterpreted. The problem here was that when this sonogram was done, the person doing this sonogram was not aware of the plain film findings. And you can see there's a healing fracture, there's a bowing deformity, and then the question is the hip in or out? And it's a little hard to tell in this radiograph because you don't really know where the femoral head is. If you think it's here, maybe the head is in. Same thing over here. But let's just see. But this study was done, now that was an earlier radiograph. This child came around some months later for a sonogram with the challenges of being an older child, as we said. But whoever did it thought that they were seeing this cartilage here with no recognizable acetabulum, and they thought that was the femoral head, and it was completely dislocated. But in reality, it really wasn't, because this child then went to the, had an arthrogram, and what you can see is this is the same hip. When the arthrographic, the contrast outlines a femoral head, which is actually within the acetabulum. And the problem was because of the deformity in the flexion contracture, the sonogram was just showing the greater trochanter, which was out here, and didn't even show the femoral head because it was blocked by this, the ossified femur, which was in the way. And that led to the incorrect interpretation of the sonogram. So these are some of the entities that in which you can, that pitfall can exist, and this is proximal focal femoral deficiency. The hip contractures, other kind of bowing deformities. And in the end, you really have to be aware of what's the clinical story with the child and be aware of the plane radiograph. Now, a new topic to switch over is to joint effusion. And basically, with sonography is to identify a hip effusion and then perhaps facilitate aspiration of the fluid for analysis. Now, in some joints in the body, just a radiograph can tell you whether or not there's fluid present or not, but that is very unreliable in the hip, so you really do need a sonogram or other study to help you. The child with a painful hip can be from a multitude of causes, but our question here is going to be whether or not this child has a septic hip or bacterial infection within the fluid, which is really an emergency, because if that's not treated properly, this child can then get a very, very damaged hip, which will follow the child forever and might even have to end up with a hip replacement later. So basically, we're going to be talking about hip effusion. In contrast to the DDH, instead of coming from the side, we localize it anteriorly, and then whether or not can we tell if it's septic or not. And actually, we're going to see that our ability to tell based on imaging alone is rather limited. So now we're scanning from the front. And in a schematic diagram, this is superior, this is inferior, this is anterior. And the hip joint extends well down on the femoral neck, which enables us to see effusion. And when there is an effusion, the capsule is bulging, as we're seeing here. This is a radiograph of this hip. There's quite a large effusion here. This is the psoas draped over the joint. And yet on the radiograph, maybe there's a little minimal widening of the space, but that's not a very reliable sign. We've had prominent effusions, which on the radiograph you just couldn't tell. On an arthrogram, you can see how the femoral neck extends, how the joint capsule extends down over the femoral neck. Here's a big effusion. Here's a small effusion, in contrast to the normal side here, and then P represents psoas muscle on all these. Now, is the effusion containing bacteria, yes or no? And basically, we've learned that our ultrasound criteria is really not perfect. You can look at various parameters, echogenicity of the fluid, how distended it is, capsule thickness, etc. When Power Doppler first came out in the 1990s, we used that to see if that would help us. And as we'll show momentarily, that is also not perfect. Now, here's a child who had a septic hip. This is the normal side. The abnormal side, the capsule is thick, it is very echogenic. Clinically, that's what they were worried about, and they got pus with Staph aureus. And this makes sense, but we also have had septic hips where it didn't look anything like this at all. It looked rather clear, so you just don't know. We did a series using Power Doppler to see if that could perhaps help. And you adjust your settings on the normal side and keep the same settings. You go to the abnormal side, and you can see there's a lot more intensity here of the signal. And it ended up that if we saw the increased signal, that was good evidence that it was septic, but it didn't work the other way. If you didn't see it, it didn't eliminate the possibility that it could be septic, so you still had to analyze the fluid. We also did this with an animal model and really found the same results. And you can see here it was a septic hip, but early on, when we were producing the septic joint, for the first several hours or so, it really didn't show the inflammatory signs yet. So if it's a little earlier in the course, the Power Doppler might still be negative. So the bottom line is if it were positive on Power Doppler, it's likely septic, but if it's negative, it doesn't exclude the possibility of it. Clinicians in various centers have also looked at certain clinical criteria. In a study from Boston, 2 studies from Boston Children's are looking at these 4 criteria. And basically, if all 4 are positive, it's very, very likely it's a septic hip. If all 4 are negative, it's very unlikely that's a septic hip. At University of Michigan, one of our orthopedists also looked at with C-reactive protein, which adds a little bit more specificity to it. But again, these are not perfect studies either. So basically, you still have to, clinicians have to use some clinical judgment in trying to figure this out. And once again, this adage comes back to remind us all that the world isn't perfect. So basically, sometimes you still have to analyze the fluid. And once we've detected it, sonography can be useful to help localize it and then to help obtain fluid. And a few ways you could do it. Now, knowing that you want to go over the femoral neck, you can really do your sonography, locate the effusion on longitudinal view, locate it in transverse view right there, and kind of X marks the spot. And then if you don't want to use imaging to actually put the needle in, just go straight in at that point, and you should be able to obtain fluid. If you're having trouble, then you could put a sterile cover on the transducer and then take a look and see where you are. Some people actually like to do it under guidance. Now, this animation from Dr. Shields, who's a well-known pediatric interventional radiologist, uses a lot of ultrasound, and he had this made, which really just shows aspiration of fluid under sonographic guidance. And here's a case that we did. And you can see you're pushing on the capsule here. And then in the next movie, you can see the needle is present. And then we'll be aspirating the fluid. So this is all the orientation. This is what the fluid looked like here. And after the needle is in, they got this straw-colored fluid, and then you send it to the lab and have that analyzed. Another case where it's a good bet that that's going to be septic, but again, this isn't foolproof. You just don't know. Now, this brings up a little caveat. This is going to refer to the normal side that I had in the last slide, and here it is here. And there's 2 aspects. One regards the femoral head, and one regards this little echo right here. So, first of all, be mindful in children that they have a lot of cartilage in their epiphyses. They're not like adults with just a little bit of articular cartilage. So I've seen people misinterpret this hypoechoic cartilaginous portion of the femoral head as fluid, and it's not fluid at all. So be mindful of that. The second thing is that when we're looking for the fluid, we're looking for it down as the joint extends over the femoral neck. You may also see a little echo in the femoral neck right here, and you could see this with or without fluid in the joint. And if you do see it, don't misinterpret that as meaning that there's debris, echogenic material within the fluid. This is just a posterior reflection of the joint capsule, and it's a normal finding by itself. So we had a child who came in. This is a typical story which you might see in your emergency department. And here's a radiograph which really doesn't show that there's any fluid. And they did find an effusion, but the person who was doing the sonography also observed that the surrounding soft tissues on the abnormal side didn't look quite right. There's some increased echogenicity as compared to the other side. And actually coming up over the thigh, so there was more than just an effusion. There was this subcutaneous layer was all very echogenic. Within the muscles, there was increased echogenicity. There was some hyperemia. In contrast to the normal side, where you see your nice normal layers and pennate structure of the muscles. And this is in short axis. This is an anatomical diagram. You can see the normal side, well-defined muscles forming going to form the quadriceps, and abnormal on this side. And this is a child that actually had a pyomyositis This is a cine loop showing that area. So you don't want to just have blinders on and tunnel vision when you're studying these children. Here's the short axis. And this could be anywhere in the body that you might see this. Other possibilities of an irritable hip that you could come across when you're looking for a hip effusion are many. And I'm just going to show briefly with this is a psoas irritation, or a psoas abscess can present just like an infected hip. We really did not find an effusion here, but the psoas muscle looked rather thick. This is a case from Dr. Harkey. Now I'm going to show it on some CTs for orientation, but you could have done the whole thing with ultrasound. But notice as you're heading up into the pelvis that there's all these fluid collections. And this is all abscess along the psoas. Now an advantage of CT is a more global picture, or an MR could show you also. If you have extended field of view, perhaps you could get a broader field with sonography. But very often sonography is the study that we start with, so we just want to keep in mind to check along the psoas if you're not getting all your answers just over the hip joint. Here's the sonography in that case, just showing comparable pictures. Well up into the pelvis now, and here it is on ultrasound. So I think the sonography pretty much shows you the extent, but sometimes for the clinicians, the CT or MR gives them a better broad perspective of what's going on. Another case with an irritated psoas, doesn't necessarily have to be infection. It was a case that I did, and went down to the emergency department and saw this small effusion, but in talking with the patient, he said actually the pain was also going a little bit higher, so I scanned up along the psoas. This history was not given to us at this time, that he had a neuroblastoma a few years before, and as I scanned up along the psoas, here it is in long axis, there's a mass sitting right on it, and here it is in short axis. That was irritating the psoas, and we think the effusion was actually sympathetic, and this is a transverse view. Here's the ilium, and there's this mass sitting right on it, and this was actually a metastasis that had dropped into the lower abdomen, was growing, pressing on the psoas, irritating it, and giving this child hip symptoms. You can also see cases where there's more of a myositis again, or an osteomyelitis. This is a child, now we're moving to the knee a little bit, but the principles are the same. And you can see in musculoskeletal ultrasound you have your normal layers broken down that we're all familiar with. This is very abnormal, very edematous, ill-defined tissue planes, very indistinct tissue planes, hyperemic, and this is a child that you can see had cellulitis. Another case over the tibia, but notice that there's a debris-filled fluid along the bone, sub-periosteal, and this is a very strong suggestion that this child actually has osteomyelitis, which has to be drained in the operating room. So basically, in conclusion, in regard to DDH, what we've covered is just your basic orientation and some of the technique and pitfalls to watch for, and with the painful hip, how to identify a joint effusion, some of the problems with trying to tell if it's septic or not septic, and how sonography can help with aspiration, and then plus some differential diagnoses and other things to be mindful of when you're investigating the hip. Thank you very much.